This is Mike Kulwick, and welcome to Dental Insight. Today is part two of my time with Dr. James Clem. James, again, welcome. It's great to be with you.
Great to be here, Mike. It's always an honor. And again, we go back a long ways in our careers, and we've had connection for probably almost 40 years.
Yeah, a lot of dentistry has flowed under the bridge in our careers
Isn't that
together.
the truth?
Absolutely.
Yeah.
I'm just so excited to have you back. And for those watching right now that didn't have the opportunity and really the privilege of seeing you
Yeah.
in part one, let me remind everybody regarding your substantial history in dentistry. So Dr. Clem is recognized as an international educator in biofunctional and aesthetic CAD/CAM dentistry. If you want to know more about that, go to part one because we really spend time talking about what that all means. He's known for his expertise as a speaker, author, and educator. He was recently appointed as a research and content development consultant for Ivoclar. He is a highly decorated academic, and that is he's a fellow of the American Academy of General Dentistry and an accredited member of the American Academy of Cosmetic Dentistry. In addition to practicing in California and Idaho, where you're in Idaho today, Dr. Clem founded the Clem Institute. We'll spend time today talking a bit more about what he does there. And last but not least, he directs the Institute's online educational training programs and at the same time hosts the podcast, We Talk Dentistry. So James, clearly you've not been letting the grass grow under your feet these years. You've accomplished so much. You're a wealth of knowledge both on the relationship side of dentistry, which we spent a lot of time on when we were together last. But today, what I had asked you for was the privilege of getting together again and really focusing on the clinical side and the material side. You truly are an expert. So let's dive into that, shall we?
Absolutely. I'm excited to talk about it.
Well, you know dental materials well, but you also know the digital side of things very well. Where do you see the impact today when it comes to this term digital dentistry as it relates to the dental office, the in-office lab, and if you will, the commercial lab workflow as well?
Yeah, there's two sides to that. It's how you gather information. We used to do it analog and send things off to a lab. Now we're doing it digitally. Now, I've been doing in-office CAD/CAM dentistry and printing for quite a few years now. And I just like that. I know most of my colleagues will have a digital process where they gather the information, send it off to a digital lab, and work in that conjunction through clouds and using AI software. So the workflow that we see from the office to the lab and back to the office is changing, and it's impacting material as well as what we use in the processes. The fundamentals are still there. We want to abide with the fundamentals that we've all learned and try to acquire each day in our office. But the workflow, I feel, is much better. And I see laboratories jumping into this really strongly now. It took a while. But we know that the digital information that we can acquire with the latest digital cameras, and there's a lot of good ones, is more precise. I did a lecture on this 4 years ago at the CDA, but the digital information that we can acquire and send to the lab is more precise than an analog impression, which makes that trickle chain effect work. Because I know you ran a high-end lab for years, and the last thing you want to do is have a doctor have to send something back because it needs to be tweaked.
Right.
Whether it be color or the way things fit. And with the digital workflow now, we can be more predictable, save more time clinically because we have more precision. And I'll tell you, my big deal is I don't like to adjust occlusion once I get a prosthesis or a restoration into the mouth. And I think that's the benefits that we see both from the laboratory and in office outcome. And that's what I teach, is learning how to understand the digital workflow so it's a win-win for everybody.
James, if I may interject, you graduated from Loma Linda. How many years ago was that?
It was 1984. So in fact, this month is 40 years for me.
So when you look at these years, right, these 40 years, you just take us briefly through from your memory where things were right out of dental school and how they've progressed to today, because that word digital really didn't mean much in 1984, did it?
Didn't mean a lot. There's some parallels, though. I had a conversation with a podcast last week for the AGD, and I know back in dental school, I had this curiosity with gold foil, mainly because of the precision, the artistic side of it, which there was with the prep, because you had to prep it just right. And then you apply it in the prep and you condense it, you polish it, and then you look at the reflection like in a mirror. That precision now has all gone digitally. So I think that same essence of my appreciation of dentistry and the precision of dentistry has now gone in digital. But who would have ever known? Like, for instance, I'm up here at my ranch at my research lab where I have a full chair and I have technology behind me that I hope to keep involved with. So what digital dentistry has done for me is it's recreated that passion that I started in dental school, and then I found my why in the journey, and now look where we are. There are commonalities between analog and digital, and that would be the standards that we've always set from a functional and biology standpoint. We still pay attention to that, but we just apply it more into the digital workflow now. But no, it's pretty different than what I would have imagined 40 years ago.
When you describe your practice, because we have clinicians with us right now where they don't make anything restoratively in the office, right?
Mm-hmm.
No definitive
Mm-hmm.
restorations. Just can you walk us through where you are today and what you are delivering in your practice for as compared to what you still rely on outside laboratories for?
Now I'm a little bit of a geek, so I do everything, right?
Okay.
But let's talk about how I coach an office. I coach a lot of offices just with digital cameras, and everything is with a digital lab. So let me address it from that standpoint. Back to diagnostics. Everything starts with diagnostics. Like this week, I did quite a few new patient exams, and everyone had a CBCT. So I'm looking at more than just teeth. I'm looking at the joint, the sinuses, the neck. I have a large enough sensor screen where I can see the neck and see the balance and the skeletal balance. So those conversations we have with our patients will help us look at a deeper level. Sleep apnea, so many things that we now can look at, even though sleep apnea still needs to be diagnosed from a airway standpoint. We can see a lot of airway tendencies on CBCTs, and I found them to be pretty telling on whether there's going to be a problem or not. And then once we have that information and we have that conversation with the patient, then we decide treatment based off of a really sound diagnostic panel or multiple panels based on what your expertise is. I didn't say that right. Based on what your expertise is. So once we have that in our understanding, then we create treatment plans. I find that treatment plans are often reflective on what you know. So you're going to see what you know. And when you see that, that conversation changes. So for instance, when I look at offices and I help coach offices, so many dentists, when we get out of school, we're into that crown here and there in a quadrant. And I have general patients. I don't overtreat. In other words, I don't want to treat more than what nature has provided for a patient. Then as you gain more understanding, and we're in that stage now. In fact, I'm putting a lecture together for True Abutment seminar here, and I talk about the continuum of time with age and how that impacts the mouth. We now have patients that are keeping teeth to a larger extent. So when you understand the aging of a mouth, you start thinking different diagnostically. So that's that understanding of the fundamentals of biofunctional dentistry and just general dentistry, working those things together, I enter that into a digital platform, such as my study models are all digital. My diagnostic wax ups and changing vertical, even though I use the mouth as a vertical articulator, that goes into a diagnostic wax up, and everything is managed through a digital platform, whether it be all on four, which I don't do a lot of, but I've been involved with that. More what I do is more around the aesthetic side, with where I love veneers and ceramics and comprehensive care, where I'm changing verticals all the time because of excessive aging, or maybe they never developed a vertical that's working for them for one reason or another. So I want to enter that into a digital platform. So when I'm done and I'm completed a case, I've never missed a beat down the road. Now, laboratories are doing that. In fact, now you have design laboratories that will design your diagnostic workup, and then they will walk you through everything you do, so that you have these clouds of where we're overlaying the CBCTs with digital scans and doing facial analysis to create facial diagnostics with the restorative dentistry and the vertical side of things. It's pretty amazing of where we can make this workflow really smooth. And that work that you do with a laboratory is just, you're not guessing at all. And the laboratories love it. The laboratories that I have worked with, and in fact, I just taught at the AACD, and there were a number of technicians in my class, and they really embrace the digital side because it allows them to communicate better with their clients. And really what we're after is the patient winning. And then when we're in the office, and I said this last time, your why is to be the best you can to find your focus in your practice so you can have your joy factor. So when you go home at night, you have a better family life. And that's what life is all about for me. It's all about the family.
Absolutely. And it's that balance that we talked about when we were together last time.
Yeah. Yeah.
You're balanced
Yeah.
outside of work.
Mhm.
It enhances and brings joy to you as you walk into your profession, to the
Mhm.
workplace, and it
Mhm.
goes back and forth. It balances together. James, I did a lecture last year.
Mhm.
Actually, it was earlier this year, to the Sacramento District Dental Society,
Mhm.
and it was part of it really was to answer the question, to lab or not to lab. Yeah, that is the question. And so I think what's going to be interesting about our time together today is the general dentist, or for that matter, prosthodontist, looking at dentistry. You really are an individual who said, I'm going to lab. And but yet you in no way are saying to every
Mhm.
colleague out there, you should be what I am.
Nope.
Now, so but what your colleagues can do is they can learn from the fact that you dove into the deep end of the pool a long time ago, beginning with CEREC, right?
Mhm. Mhm.
And you've been swimming in that pool, and now the Ivoclar pool. You've seen the progression of materials and how they've improved. You see the progression of the technology. Um, Let me just focus on something that I think is, to me, it's an important tool that will become, I think, just as valuable as a handpiece, and that is the intraoral scanner.
Mhm.
When did you take on an intraoral scanner, and how do you feel about the technology today?
Well, 23 years when we used to powder, even back then it was pretty accurate.
And that was
Though,
with CEREC.
yeah, that the reputation wasn't there, but a lot of it, how you manage a system. But the scanners now are definitely surpassing analog years ago. In fact, there was a good study in 2015 that showed that a printed model taken with a good, the top tier digital systems was much more accurate than a PVS and stone model, particularly with the trueness of the posterior, the way the teeth fit. Like if you do a a scan for appliance, and these appliances now are printed. They just drop in, and I have my appliances almost to no touch, which is kind of nice. So getting back to this digital scan, I think, in fact, I know laboratories that will actually give an office a scanner just so they can scan that information to them and develop that workflow because it's that much better for a lab.
Yeah.
Now, look at the lab workaround now. I know labs still are pressing somewhat, but even if you press, most labs now are still designing it virtually. Then they're machining or printing out a wax form and pressing like Emacs, or if you're doing zirconia, you're going to be machining it anyway until you print it, which we know the printers for zirconia now are coming to the market real soon. So our whole future of what we do is based around a digital process. So even if we send an analog, think of it this way, we send an analog impression to a lab, right? So they're going to pour it up or take an impression of that PVS, make it digital so they can process the information and get that back to the doctor. So you just might as well bypass that analog impression because the laboratories are going to digitalize it anyway. And it saves them
James,
time and money. It saves time and money.
are we at a point now where it is almost a no-brainer regarding
Oh, yeah.
buying a scanner?
Yeah, I mean, in fact, when I look at this now, Mike, I know I live with this every day. So to me, I couldn't think of any other way. One of the things I've done in the last several years, I've done a lot of convention speaking around the world in the last 15 years, but the last several years haven't necessarily been around CEREC. It's been around digital platforms, and I've presented multiple scanning options and different companies and things like that. I'm not married to one company by any means. I'm about what can we do to get the best outcome, what works best in your hands. And there's multiple digital scanners now. I tell you now, if I were a laboratory, I would make sure all my doctors have a digital scan. It's not hard to train now at all. I mean, you see, if you can see the prep with your loops, the camera will be able to see it.
Right, right.
And so it's really easy to do. I would say it's easier than analog impression.
I think one of the factors that I've encountered, and particularly for dentists that are in their 50s or maybe even their 60s and they're not ready to retire yet, is my re-rec factor is low, Mike, and I'm not having problems, and why should I do this? And you know, I've heard about CEREC. There's, I think, an impression on the part of some clinicians that it's not necessary. Now, so I go back to you and say, okay, you know, the doctor has a low remake factor, and he's not losing patients because he still uses conventional analog impressioning. What would you say, colleague to colleague, what would you say to him or her right now? Like, take a closer look at this. Here's why. Convince me.
I'll convince you. I have this statement now that I use with my patients is, do I have permission to be candid with kindness? I'm going to be really frank, with anyone out there. The question is, how much do you adjust your restorations when they come back? That's a really good question because I don't. And even laboratories that understand how we fabricate and how we develop parameters and the digital impact of an impression where you're not having to deal with a few microns and not leaving these teeth out of occlusion just so you don't have to adjust them. I would say right there, that's going to save you a lot of time. We know that, here's another comment I've always made, is that if you're adjusting occlusion in on a crown, you're compressing the PDL, you're probably going to have some rebound, which means that patient may be back in your office for a secondary adjustment, and you're going to see probable hot and cold sensitivity in occlusion. So I would say occlusion is number one reason why you want to save time. Patient's probably not going to leave you if you're in your 50s and 60s, and you have a good connection. It's not about whether the PVS is working for you. It's about opening your eyes to be the best you can be. And I would suggest that you lose a little information with PVSs. And it comes into precision of what you would see within occlusion. And I'll ask you this question is, can you take a compressed PDL? I'm going to start over there in case you want to edit that out.
You're right ahead.
So here's the question. Do you want to take a compressed PDL bite registration so you're managing the compression of your periodontal ligaments? You can do that digitally. You can't do that analog. That will make a difference with the compression of a 30 to 60 micron average. There's various articles on that you can manage compressions of a PDL. So when you do place a restoration and you manage the occlusion, your lab can give you great morphology where you don't have to adjust it.
And that is a big, big time bonus.
I don't care where you are in your career. I've trained doctors who are in their 80s versus doctors that are out of dental school. And I can tell you the big response I get from doctors who go digital, whether they do in-office or lab combo with their scanners, will say this: my margins are better and my occlusion is more predictable.
Right.
I mean, right there, why not?
All right. So now you've convinced me on behalf of your colleagues that this is the way to go. You know, the degree of ease of use and accuracy over the last 20 years has increased dramatically with intraoral scanning, right? The ability to go through the curve, to learn how to use it, the education that's available online, the post-purchase support that's available from the companies, from laboratories, from individuals like yourself and others, to fully understand what the parameters are with the device. I think, as you know, there's a difference between taking a single unit in digital impression and a multi-unit and a full arch. There are differences there, and there are technique concerns that have to be addressed. And then you get into the world of the partially dentate or fully edentulous mouth. There are technique concerns there, but that is all part of just what's expected in dentistry, right? To learn how to use the tool.
Yeah, Mike, you bring up a good point, but let me challenge. I'm not challenging what you said, but I'm going to challenge the mindset of a dentist. The technique for a digital information highway, whether it be comprehensive or single tooth, is still easier than PVS. I mean, just imagine taking a bite and you're prepping the whole arch. How do you take the bite? Is it going to be accurate? I mean, I've done it that way, and there's some insecurities with that. I can tell you right now, I could take someone off the street and within a half an hour show them how to scan a mouth. Who's never seen dentistry before. It's not hard to do. In fact, maybe it's easier for them to learn than a dentist. So I think our protocol, for instance, you still prep the same. You still retract tissue according to the way you do it. A lot of people use cord lasers.
Right.
With a digital camera, you can use curettage. And that question was asked me last week on a podcast was, what do you do on a deep margin? Well, if you can see it, you can trace it. And it's a lot easier to see a margin from a digital standpoint than an analog standpoint. Let's suppose you don't have a drop off because you're down there pushing on the biological width, which, we all do it. And what are you going to do? If you can see the margin and blow that up 50 times size and see that pen line, just that razor blade line of a margin, and you put a tracing on that, and then you drop that crown in and take a pre-cement x-ray, it's spot on. That's a joy factor. I'm going to come back to two things of why digital is worthwhile. Mike, you got me going here, so stop me if you need to.
Keep going.
Number one, margins. And my question to our audience would be, has anyone here lost sleep over a bad margin? I ask that in my lectures, and you see the hands go up. Yeah, we've all been there. Well, I can tell you, if you can see the margin on a digital image, you've got it. Number one. Number two, I still have anger issues when I adjust occlusion. And I hate getting that crown back. And, there was the bite registration was off. Maybe people are still taking these triple bites, which is not in place. The lab did the best they could. They gave you this masterpiece of beautiful, beautiful morphology, and you're sitting there adjusting it. And I have anger doing that, and no one likes doing that. And when you're done, we have a crown that fits, but we've lost that joy factor of beautiful morphology and function. And the last thing you want is for a patient to know that it was frustrating for you, because they will see that as, did something go wrong? Or
Right.
you never want a patient to say, "Doc, is everything okay?"
Right. Yeah.
Not a good place to go.
Yeah.
And people read energy, and I can tell you, when it goes back to our last podcast, Mike, would be the way we present ourselves with confidence is about having a certainty inside that we have a predictable outcome. And most of the people I work with are using virtual labs, either for design and completing the whole process, even though I teach in lab CAD CAM and I teach office CAD labs. So I didn't say that right. Though I teach laboratories and I also teach doctors. A lot of doctors that I teach will do maybe posterior restorations like zirconia, and then they'll send everything that's comprehensive or anterior off to a good virtual lab. And it's just predictable. It's like clockwork. And staff love it. We haven't even talked about that, because team members are allowed in most states to take these impressions.
Right.
They love that ownership.
Right.
So and then the other thing is, maybe a patient isn't going to leave the office because they do digital. But I can tell you, this happened just yesterday, Mike. I had a patient that I was treating, and I've treated her most of my career. And when she's on the schedule, I'm always thinking about it, because she's a dear person, but she's hard to treat, hard to get numb, hard to get in there to work, everything. And, she's under this high anxiety. And I'll tell you, yesterday, this is what she shared with me, because she had me when I was using laboratories and traditional impression. She goes, "What you did today is so different than what you did years ago." And she says, "It lowers my anxiety to know that I can get a restoration the same day. You take a digital impression where you're not loading my mouth full of goop where I'm going to gag. It just makes me feel so much more secure in your chair." And this is like someone I've treated for almost 40 years. And it was a tough case. I was taking off 29 and 30 subgingival decay in a mouth where this patient has some health issues, autoimmune, which really compromises her oral health.
Yeah.
And when I was done with that case, I looked at my assistant and I go, "How would we have done that analog?" There was so much blood and guts in there, so to speak, of where we were able to go in there, see margins, see the restorations. They look perfect on the x-ray. I used zirconia. Tissues heal well to zirconia. So I did microsurgery. At the same time, I placed the restorations because we controlled the soft tissues. And
Right.
who wouldn't want that?
Well, James, we've gone from the Model T to the Tesla in a span of 40 years, in a way, right?
We have.
Sophistication and ease of use. And I'm so happy you just brought up that patient, because not only is life easier and better for you clinically and your staff, but the patient experience
Huge.
is better. And those is a combination that just can't be beat.
Now, could I add one more thing here?
Please.
So for those offices that use a laboratory for that, what you're going to do is you're going to scan, send that off to a virtual lab, and they'll have a design back to you within 5 minutes using AI software, and you're going to print your temps in 4 to 5 minutes. The Sprint Ray latest system is just amazing because they have these small build plates. And so you can print provisionals in 4 to 11 minutes. They're going to fit like a glove. You're going to have great soft tissue response. So when you do get that restoration back, it's going to have the same shape and profile of the digital information just sent back to you. And the assistants are doing this, and you're placing in great provisionals with great response. So when you're done, the tissues look great and you're saving time. That's going to be the future of anybody that has a digital scanner. They're going to have a printer. They're going to print their provisionals, which I do now on larger cases. They use that in combination with their virtual lab that is providing the final restorations.
James,
That's the
do
future.
you
That's what we do now. And I would say in 5 years, majority of offices will be doing that in America.
printing, not only
Oh
temporary,
yeah.
but
Yeah.
that goes now to my next question,
Yeah.
since we're in that world, do you believe that we will have successful data down the road on definitive crowns that are printed in the office? Because right now I don't know
Yeah.
of any studies, right, that say, okay, here's 5 years and here's how these 3D printed crowns are doing. What is your opinion of it today for long-term use, and where do you expect it to be in 3 to 5 years?
I think if there's going to be a component, like for instance, now I would feel comfortable printing, which I do, an inlay versus a traditional type of composite that's printed. And there are multiple studies to show that, in accelerated wear and tear facets, that the value of that type of restoration is better cured than anything we've ever done because it's cured in layers, and in addition to that, it's highly filled. So we have materials that are filled up to 70%. And a lot of people don't know this, that the free radical is what really keeps a restoration in, particularly if it's a polymer type of restoration. And they call these ceramics now. So if it's over 50% ceramic, you can bill an insurance. So I'm fee for service. That's the current policies now.
So you're comfortable for inlays. What about for full crowns as a definitive restoration?
I don't know. I'm not there yet, though. I do feel like we need to keep an open mind, mainly because of my history with Bell Glass Symphony. And even though these have better flexural strength, they're getting up to over 2. I mean, you want I didn't say that right. A fractured. I'm going to start over. The current materials out that we can print for a full restoration have a fracture toughness of 2 and a little better in 2. Emax is like 2.23 or in that area. Anything posteriorly with a fracture toughness of over 2 is going to withstand a test of time. So that's kind of like your look in that area. My biggest question about a Palmer, though, whether I'm going to use that full crown or not, would be how does the surface hold up? You have a resin in there. I've never seen a resin really thrill me way out when I compare it to a ceramic and particularly zirconia. So that remains to be seen. I don't
Okay.
know. I don't know where
So
that's going to go.
that time will tell, right? And it will continue
That will
to
know.
advance. Let's go back to the 1980s, fresh out of dental school, right? I think Empress maybe had started to appear. I'd have to look that up. Um,
1991.
okay, so it came along. Before that was things like Sarastor, and we had
Yeah.
Procera, and these different things that
Yeah.
evolved over time. And when you graduated, you were dealing with gold and PFMs, right?
And the
And
porcelain margin just came in.
pardon me?
The porcelain margin just had arrived my
Yeah,
senior year. So we felt pretty sophisticated.
and as we look at these ensuing decades, right? There has been such progress on the material side, and that is a partner with the digital progress.
Mhm.
Would you please spend some time talking about how you have seen the progress of materials and
Mhm.
what your clinical choices are today, both posterior and anterior?
That's a good question. I'm going to answer that 2 ways. Number one, I know what's used from laboratories. We know everything now can be printed, whether it be a lithium disilicate. In fact, at last midwinter, they had a printer there printing lithium disilicate, which a lot of us are familiar with. That lithium disilicate is about 23% of prescriptions at laboratories. Over 50% is zirconia. They have printers for zirconia now. Now you have printers for these, I'll call them polymer type of ceramics. So those are three components that we see. I think gold's out because it's just not significantly used anymore. I've done really good golds through the years. I've done really good gold restorations through the years. I think my issue with gold is how do you seal it? And these newer materials such as lithium disilicate, your zirconia, and these polymers, you can seal those biologically, and that's a better situation for a tooth than gold. And we do have good wear factors with these materials. You know, zirconium polished is kinder to the opposing dentition than a class 4 gold, but it doesn't wear as fast. These new type of ceramics that are printed, as of right now, what I've seen, they're very close to natural enamel wear. We don't have the perfect enamel wear factor yet. I think Empress was the closest to it. It would wear like a natural dentition until it broke. So if we have something that doesn't break, we don't have the perfect case scenario anymore. I didn't, Mike. Yeah, I know you'll cut this out. I'm struggling a little bit today because I've just lost so much sleep this week.
Yeah, no, you're doing fine, James.
So let me start over again on that one. When I look at my standard, and when I look at the standard, and we've always looked at gold as the standard, it wears down too. In fact, I'm replacing gold that have perforated that I placed 35, 38, 40 years ago. So nothing's perfect, so, because the mouth is a wear factory. I do think, though, we want compatible wear, because if one material wears the opposing arch, then it will create impacting cusp, and that creates a restorative problem later on.
Yeah.
And I've done that. I've seen that in my work through the years. But I do think there was a push 20 years ago that maybe the future would have been these polymer type of ceramics. I think there's a new push in that because of the ability to print. With printing, you have a better curing environment. And I don't know where it's going to go, but I have this hunch, Mike, that I think that we're going to see a new box formed. That's going to be quite promising.
But right now in your practice, first molar, what are your options?
I'm going to use either Emax or zirconia. If it's high and dry, it's Emax. If it's subgingival, I'll use zirconia, and I can make zirconia look in the shadows of the mouth as good as Emax. If it's
so
a part,
you're using a multi-layer translucent zirconia, is that correct? Probably in the 800 megapascal range.
Well, that would be a 5Y. So most of us are now using 4Y in that area, which is popping you right up there to near 1,000. And more importantly than that is the fracture toughness. So all of the 5Y and the 4Y and 3Y, now we have 6Y too. I don't know what those metrics are, but 5Y is still good posteriorly. You just need to have it thicker. So when I'm looking at zirconia, I'm thinking it's either 1 millimeter minimal thickness, 0.8, 0.6, based on where you're at. In fact, yesterday I did one in 3Y, and I infiltrate before I place that in, so it looks decent, mainly because I needed something at 0.65.
So James, I'm going to interrupt you for the benefit of our audience. Gordon Christensen published a nice CRA update a couple of years ago about the Ys, 3, 4, 5Y. And I think for a lot of us in dentistry, both as clinicians and non-clinicians, what we want to know, particularly from a James Clem, is, well, what should I be using? What questions should I be asking my laboratory? Or if I'm going to be going into this world of milling myself, what are the definitive factors here for you in
Mhm.
talking to me as a general dentist when it comes to, hey, here's what you should be thinking about when in the world of posterior zirconia? Do you have any thoughts on that?
Yeah, I'm not going to get into the tragonol and
Right.
cubic and components of that because that gets a little boring. Most people that send something to the lab, they're going to use whatever works. So laboratories are looking at the time, the space, how much time, how much space do I have, and then they're going to choose a product. What we have now is like Ivoclar makes a unique product where you have the cervical side of your restoration in 3Y and then the coronal side of your restorations in 5Y. It's almost like a layered effect. So you get the 5Y is more translucent. That can look just like Emax,
Right.
whereas 3Y is really opaque. You want to cover that up. So we have those options. And then they also make another product that I use a lot. In fact, I can interchange that with Emax in the mouth and it'd be hard to tell. And that would be their Zircat MT Multi, where the cervical side is 4Y, which is really strong. And then that's covered on the viewing side of the block and the coronal side of the block.
So let me
5Y.
just
So the 5Y can be translucent like a ceramic.
well let me interject a point there. Because
Mhm.
as you know, I had 45 years in dental technology
Yeah.
in operating a laboratory, and it was very much into material science, and was a dental nerd myself, and just reading Skinner's Science of Dental Materials, and
Which means you still are.
yeah, I still am, and I'm still reading all of this, and I do have an affiliation with a laboratory that I highly recommend. But having said that, would you agree that if a clinician is getting back, pardon my French, butt ugly posterior zirconia, they don't need to tolerate that. They
No,
Laboratories now have
yeah,
available to them material choices and with proper handling that are just like Emax. Would you agree with that?
I would totally agree with that 100%. In fact, Europe is going that far. In fact, I have a case I did in my lecture where I'm doing a Prado number 3. It has a lot of characteristics in the mouth, almost a little tetracycline. And I did just as what I do for a study where I used a 3Y zirconia, which is a really high end zirconia that's strength, but it's very ugly. And then I used one of these higher translucent zirconia. But for the 3Y, which is the really strong zirconia, I used infiltration techniques. And then I showed them a picture of them just dry seated. And I put the quiz up there. Which one is 3Y, which is the high end aesthetic crown? They don't get it right.
Right.
Of course, it's in the shadows of the mouth. So I think here's the point. A laboratory could take a 3Y zirconia, which is the really high-end strength zirconia, and make it look very acceptable in the shadows of the mouth. That would be first molar back.
Right.
But as far as the aesthetic zirconia, you have Katana out there. I didn't even mention that. We have some and there's other brands that are great. Those are the ones I've worked with. But I would say a laboratory now that understands this could send you back a zirconia crown, and it would be hard to tell the difference in today's world when they really understand how to process it and finish it and do this without cutting back and layering ceramic on it. Of course, I'm layering a thin layer of ceramic with Mio, which is a brush on ceramic.
Yeah, and
And
that
that,
is an incredible
yeah.
adjunct to
Hmm.
creating beautiful restorations, right? Be
Yeah.
they lithium silicate, lithium disilicate, or zirconia. What a great invention it is. And for our audience, if you want the highest level of characterization
Yeah.
from
And
your
I'm sorry,
laboratory,
Mike. I'm
ask them, do you guys know about Mio? Are you using Mio? James, you would agree with that. You use it yourself, correct?
I'm sorry, Mike. I'm geeking out right now. Can you tell? I'm totally a geek on this because I told someone if I were to come back and do my profession again, I think maybe I'd be a laboratory technician because
Well, you kind
I
of have
get more
the
joy
best of
from
both
that.
worlds,
So
right?
I have both sides of the bench.
Right. Yeah.
And I'm not saying I'm the best laboratory. I'm not saying I'm sorry, Mike. You're gonna have fun editing this one. I'm not saying I'm the highest end laboratory technician in the world, but I do pretty well, and I lectured at pretty substantial
Yeah, no,
conventions
I
on it.
think the work product
And
coming out of your clinical theater and
I love what I
laboratories is very
do, but
good.
I'm here to inspire others, and I'm not here to talk everyone into in becoming a lab technician because most dentists aren't going to do that. But I think it's a perspective that I have now that I've done both. My goal, particularly up here at my stage in life right now, is to keep tweaking. I love
Right.
to sit and tweak things and say, what can I do to be better?
All right, let's change direction. Let's go from the posterior to the anterior. Okay. And again, a lot has changed from when you left dental school to today in your clinical theater, as you call it, in the anterior. What restorative materials are you using?
I'm going to step back for a moment and say I don't want to prep a lot.
Okay.
So I want to preserve minimal invasive prepping. So anteriorly, I'm using either lithium disilicate. I still love Impress, and I'm using some Emax. I'm sorry. I'm going to start over. So anteriorly, what's my go-to? I don't know if I have one go-to anymore because I love Impress. I've used that for years. I love Emax because I can make that at 300 microns. But having said that, I'm starting to tweak with zirconia really thin. We can bond zirconia in very well. Europe is going aggressively productive with zirconia anteriorly, just
For
not
veneers,
crowns.
for
They're doing
veneers
it.
and full crowns.
Yeah, they're doing it for crowns and veneers. And the value of zirconia on a veneer is you can go really thin with it. It has translucency if you want it, and you can finish those just like a knife edge margin, and you can finish those down to 200 microns.
And if you take
And
a tool like Mio, right,
yeah, it's magic.
your laboratory, or you, if you decide to go there as a clinician, you can create something that just is absolutely spectacular, right?
Yeah. Yeah, I love Mio. I have a good relationship with Jensen. In fact, I taught a class on Mio at the last AACD. And Mio in my hands has just been magical. In fact, I'll make this statement here, Mike, because we earlier were talking about Impress. I think some significant things that happened in my career was for aesthetics. That would be Impress, early 90s. Emax, 2005, I believe. And then Mio. I put Mio in that same category. That's what goes on these restorations.
Right.
But there's just something magical about it that preserves the monolithic behavior of your ceramic. So we're not cutting back in sizel edges, putting on weak ceramic because we're trying to make it beautiful. And that's going to always be the weak link in the function of that restoration down the line. I've seen it in my practice where 13, 17 years out, you'll see some delamination of that layered effect. So with meal, we can go more monolithic and get the effect as if we had done a cutback. It's the best of both worlds. And I see laboratory technicians that are really pretty high end starting to go that route.
And that leads me to just a bit of a sidebar comment relating to the Clem Institute and what you're doing with CADStar. You have videos that show how to use Mio, that instruct the
Mhm.
clinician. I will
Mhm.
make the point that if I was a clinician right now, I would be telling my laboratory colleague, please get a subscription as well. Take a look at what James Clem is doing, because the fact is, you are an expert in the laboratory arena, and I would want my laboratory to like a sponge take what you know and pull it into their laboratory. So well done there. And that's, I think, what makes your efforts so much appreciated on my part. And I underline this again for the benefit of dentists as well as laboratories. I think laboratories tend to have an ego at times. We all do in life.
Oh, we all do. I do.
And it's like, well, what does this guy Clem know? I mean,
Yeah.
he's a dentist. Well, no, he is a master technician and a master clinician. And I mean that with the greatest sense of appreciation and respect. We have to be open. We have to be open to learning, and that's the basis of progress. and it's the basis of providing the best level of care, and success to the patient.
You
So,
know, just one.
James, without further ado, what is the Google search? It's going to be Clem Institute or cadstar.org, right?
Well, let me mention something because I believe in
Sure.
being abundant. In fact, you can find a lot of my Mio videos on just James Clem DDS YouTube.
Okay.
I give a lot away. And I do have an online site, cleminstitute.com or cadstar.org, that's focused with a little more detail and a lot more information. Believe it or not, Mike, through the years, I have over 800 videos on there. People don't have to watch them all, but if they miss me, I'm there for you.
I hear you.
But I do enjoy. In fact, that's what I do up here at my studio here. This is a content creation mecca, and I just
James, let
enjoy
me
doing
let me
that.
interject a quick point because we only have so much time together today. Let's go into the world of removable. Okay,
Yeah.
this is by the time I reached retirement as a laboratory owner, my excitement for 3D printed removable
Hmm.
was getting to be very palpable and going, here we are. We finally have on the denture side materials that fit well. I'm talking about 3D printed and are not going to break. And they've gotten stronger and stronger. For example, Desktop Health with their Flexera Plus material, Flex Plus Ultra, it's
Hmm.
another 30 some odd percent stronger. So some of these early issues relating to 3D printing and breakage and have been successfully addressed. And certainly the milled complete dentures have had the strength from the very beginning. But my point right now is, let me just interject, removable partial dentures, which James, as you may remember, that was my dad's specialty, right?
And that was your specialty too.
And my initial specialty, right?
Yeah.
He started out in World War II, after World War II, where gold was still cheap and had a
Yeah.
lot of gold partials, and then cobalt chrome became popularized. I ended my career where selective laser melting, a
Yeah.
James
Yeah.
Bond type laser created routinely partial dentures that were
Hmm.
every bit as good as what I did on my best day.
Hmm.
Porosity free, incredibly strong,
Hmm.
beautiful, beautiful fit. That's where we are with partial dentures today. The
Yeah.
need to
Yeah.
cast, the need to cast has gone away.
Yep.
And we have a better product. I believe the same thing is true now with complete dentures and splints, uh, the custom tray in a dental office. A laboratory can produce an amazingly beautifully contoured, precise, aesthetically pleasing custom
Hmm.
tray. Why would you want to do anything else as a laboratory? So I will stop there and say, what are your thoughts about the world of removable devices and where we are today?
I think it's fascinating. In fact, right behind me here, that's the PM7. So that does a full mill, both of metal alloys and the denture. And that's for years, that's been considered to be the strongest as far as acrylic management system. I'll throw this name out there. I've always followed Lee Culp, and I just watched one of his podcasts. And with the way they're curing and finishing these printed bases, they're now outperforming the millable.
Right.
So I think from a alloyed and a acrylic type of process, we are definitely higher in strength with the printed outcome now when it's done right. And we have to understand. I just heard a lecture, and I'll do a shout out to the Mod Institute. They're leading the world in education and printing, and their point is that you have to have the proper printing for the material with the right wavelength. Not all light is the same. And then post printing curing is really important to establish this type of strength. Um, and again, I have multiple printers. I have a Sega, but I'll tell you, I've watched Sprint Ray now for a while, and their founders they have PhDs in printing from USC, at least their our mayor does. And they just showed me where they actually have aligners that are fully printed now. So we're going to bypass the thermoform aspect, which is going to change dentistry. And their whole focus is finding a way from a digital standpoint to elevate what we do, whether it be frameworks, acrylics, crowns, zirconia, lithium disilicate, alloys, you name it. The world now and the future of our world, I'm sure will be printing. I think we're going to do additive rather than subtractive, which
Yeah.
is what milling is.
Yeah.
I so as a result, I have to stay young, Mike, because I don't want to quit anytime
Well,
soon.
I think you are going to stay young throughout your entire life, and may that go into the triple digits, my friend, for both
Yeah.
of us. And that possibility exists more and more so. So, would you agree then that if you're a general dentist today, in addition to digital impressioning, take a look at 3D printing?
Hmm.
And but don't assume that it's as simple as buying a gumball machine.
Yep.
There you have to go through some learning curve there.
Hmm.
And I think based on what you said earlier, take a look at it for printing your temporaries. That certainly is a viable
Absolutely.
option at
Yeah.
this point. And even when it comes to removable, printing a custom tray, if you're doing a fair amount of removable in your practice, wow, you're not waiting for the laboratory. You may have sent them a digital impression, but you still
Hmm.
have to wait for that custom tray to come back.
Hmm.
I think if I'm in your shoes, in the clinician's shoes, those are two things I'm going to take a look at. And
Hmm.
last but not least, yes, I'm also going to take a look at splints and
Hmm.
recognize that, okay, if I have the right team, we talked about this when we were together
Hmm.
last, this is a team sport, dentistry. You have the right players, boy, there's some amazing things you can do with doing certain aspects of what is lab, and bring that into your practice, whether that's milling and 3D printing. Would you agree with the
Oh,
general
yeah.
assessment?
It's amazing. And I'll tell you, a lot of my colleagues, you don't have to be a software wizard to make this work. You can have a virtual design center, a cloud, and there's a lot of them out there where you send them the information, they send it back, you print. In fact, now we have several products now for splints that as it prints, when it's done printing, it's already glossed. You don't have to go in there and polish it.
Yeah, Lux Creo has that, for example.
Yeah,
Right,
and Sprint Ray just came out with one, and also a Sega has one.
right.
So that's what I see happening with other materials is what can we do to streamline the process, accuracy. I mean, I love appliance that pops in. I've done a normal of partials with a full digital scan. In fact, my last one was a class two upper partial, and I kid you not, Mike, I did no try-in. We went from start to finish. We had the bite down. I said, let's just try this all in one aspect. I popped it in. Occlusion was on. I
Yeah.
didn't even see the patient for a post-op. Why
Isn't that isn't
I offered that, but he was fine.
isn't that amazing when you
Yeah, I
think
never
about
would
the
have seen that years ago, but everything was digitally formulated and well designed and formulated.
but I want to underline that point. There are instances now with partial dentures where if we have if you will, a smaller number of teeth, right, and
Hmm.
we're opposing dentition, where you can go straight to finish,
Hmm.
as you just did. That is night and day
Hmm.
relative to where we were 10
Oh
years
yeah,
ago. So major pluses there. James,
huge.
as you look to the future, you've made this point that 3D printing will become dominant.
Yeah.
Correct? Even though you're living in the world of milling today with milled zirconia, and certainly it has its place. It's withstood the test of time thus far. But you are of the opinion that 3D printing will continue to advance, and we can expect to see things, if you will, trickle into dentistry. Hopefully, we won't be asked to be guinea pigs. I think that's one of the things that has changed in my career is there is, to me, an increased orientation toward evidence-based dentistry, which I
Hmm.
think is very important. You and I both experienced things that
Yeah.
came in through the lab end where the evidence really wasn't there like we would have liked it to have been, and failures occurred. We want to avoid that wherever possible. And I
Mm-hmm.
think I think it's important for clinicians right now to raise that question with manufacturers. For example, 3D printed crowns. You're of the opinion, hey, it's not there yet, but you expect it will be. You approve of it and are using it as a temporary material. There are clinicians out there, as you know, and Sprint Ray has a cadre where they're using the material as a definitive restoration. So, just because you might have a particular opinion doesn't necessarily mean it is the absolute rule. There are others who have faith in the material.
Mm-hmm.
And like Art Kroll told me as a young man, in coming into the dental lab profession, the test of truth in dentistry is time. Time will tell where we are with these materials as they're being placed today. Would you agree with that?
Yeah, you have to go with the time. I think when I have 40 years of experience of where I did a lot of polymer type of restorations that were fabricated at the lab, and then I machined them and do subtractive approach, the fits of them are magical. And I still use them for certain aspects. For instance, inlays. I don't like to do direct composites unless it's really minimally invasive, like on a young person. But if I can machine something and print it and place it within a tooth, whether it's printed, I'm comfortable with the print versus a machined polymer type of material. Now for an inlay, I'm really 50-50. I could go either way. Now, in fact, there's some advantages to the printing because you're going to get a better bond long term with the free radicals that are available on a printed polymer. But having said that, I do feel that I don't want to be the first one in. For instance, I do a lot of beta testing, right? And when I do that, I have a certain patient I'm going to do it on. They're going to know I'm beta testing, and I have to be responsible to follow up if something doesn't go right. I don't put that into the main volume of my practice at all. In fact, when I practice, I'm going to use something that's true and tried and that I would feel comfortable placing in my own mouth. Of course, I'd probably take a few risks there, but my family or someone I really care about. And now that I'm in my, mm, I'm beyond 65 now. I don't want something to come back and bite a patient when I'm gone from a practice, let's say 6 years out. I think about that because when I'm gone, I don't want someone else to recover
Right.
maybe something new that I tried because I really care ethically about that. So I do know that the track record of zirconia and lithium disilicate are unsurpassed. I would put them right up there with gold now. I know some of our viewers may have a hard time with that, mainly because I can't seal gold as well.
Yeah.
Can these
James,
materials?
you just really, as an end cap to our time today, I think you just really summarize it that
Mm-hmm.
lithium disilicate and zirconia are well proven materials,
Mm-hmm.
right?
Mm-hmm.
And
Mm-hmm.
there's certainly things that the clinician and the laboratory need to be aware of in order to make the best decisions possible, depending on the case, right? It's not plain vanilla paper towels. I mean, it's important that clinicians and laboratories really treat the material end of what we're doing in dentistry very seriously. That means you have to do your homework. So along those lines, when it comes to homework, you are available both the free James Clem and the paid
Yeah.
for James Clem. But separate from that, in talking to your fellow colleagues, where else would you point them to for staying with it, for really understanding, and without pulling out the science of dental materials, how do we stay current? How do they stay current in understanding materials and understanding choices? So what other areas would you point to? Organizations.
Thank you. That's going to go back to one of the comments I made in our last podcast, and that's educate, educate, educate. Now you're asking, where do you go for that? There's a lot available online now. We have that available. I learn a lot on YouTube. Of course, you have to discern. I am a big fan of developing comprehensive care understanding. Like I'm a big fan of John Coyce and his institute and his instructors there. You have Spears, you have Pankey. Wherever you go, these institutes, and I'm leaving a few out, and I'm sorry, but at least I have firsthand knowledge of these people. you're going to find a wealth of information there. You're going to see it scientifically based off of
Right.
evidence. And there's a lot of other institutes coming along now as well. But those are some of the top ones. When we understand patients up here, we look at them differently, as I mentioned when we started this podcast.
Right.
And then you'll be with mentors that have good discretion.
Right.
I feel like even though I do a lot of beta testing, I have pretty good discretion. And a lot of it just comes from my biases, which I hope are balanced. I hope. Because I've had some disappointments. I'm not going to talk about these products out loud, but I would say I've used some products in my career that cost me over $100,000 of recovery. We
Right.
call those updates and upgrades before you planned on doing them. And you're not going to charge a patient, right?
Yeah. Understood. Well, James, I want to thank you again. This has been an extremely
Yeah.
informative, productive time. I know your colleagues in the profession that have spent this hour today, I would hope that they've wanted to take notes. Maybe they have taken some notes. The progress that's been made over the course of our mutual careers has been significant, and I think we should be proud of where dentistry has gone, to this point. Things have gotten better, and we have to thank the researchers, material scientists, the manufacturers, and general dentists and specialists, prosthodontists and beyond, for everyone's dedication to wanting to become better, to provide the best possible product and care to patients.
Yeah.
So I know that dentists have a very stressful profession.
Yeah.
Yet it can be, as you have pointed out, can be very rewarding. So I think the ultimate point here is it has gotten easier. There's more to know, but it's easier to create success than perhaps it was years ago. Would you agree with that?
I would agree. And another thing I want to bring to this discussion is these laboratories that are staying up with this technology, they're your best friend because
Right.
they care about you being successful. And find good mentorship, find good camaraderie, because it's a team approach. It's totally a team approach. And when you're going as a team, it's going to be hard to make a mistake.
Yeah. Makes life easier, doesn't it?
Yeah.
James, thank you. Thank you so much. There's a little inkling inside of me that says, I think we're going to have reason to talk again.
I can.
But these two sessions together have been not only delightful, but they've been informative and educational. Thank you very much.
Thank you,
Very
Mike.
much appreciate it. Ladies and gentlemen, thank you for joining us with Dr. James Clem. Till next time, I wish you the very best. Thank you.